ECG shows tall peak T waves in leads V2 to V4, noted as C2 to C4 in the tracing. In addition, there is prominent negative component for P wave in lead V1, suggestive of left atrial enlargement, and tall R waves in V5, V6, indicating left ventricular hypertrophy. Tall T waves could occur both in hyperkalemia and hyperacute phase of acute myocardial infarction. Occasionally, tall T waves are normal variants as well. Tall T waves in lateral leads along with tall R waves may be noted in left ventricular volume overload. But in this ECG, tall T waves are not seen in the leads with tall R waves. In hyperacute phase of myocardial infarction, the tall T waves have associated ST segment elevation or a rapidly upsloping ST segment. Sometimes it may be seen in hypertrophic cardiomyopathy as well, though more common finding in hypertrophic cardiomyopathy is giant T wave inversion. Rarely, tall T waves can occur in acidosis without hyperkalemia. In a study, amplitude of T wave in V2 was positively correlated with hydrogen ion concentration. These T waves were also symmetrical and narrow-based, the so-called tent-shaped T waves. The T waves were taller during acidosis than after correction. In this ECG, in addition to tall T waves which are more peaked than in previous ECG, QRS complex is wide and has left bundle branch block pattern. There is ST segment depression and T wave inversion in the lateral leads, though the T waves are very tall and peaked in mid precordial leads. Left bundle branch block pattern is characterized by wide notched QRS complex in lead V6 with secondary repolarization abnormality in the form of ST segment depression and T wave inversion. The opposite pattern of wide S with upsloping ST and upright T is seen in V1. Here are the references for this topic.